Vishnu sir, are you ready, sir?
Professor BSK sir.
Sir, 1 minute. Vishnu sir, are you ready, sir?
Sir, I'm ready, sir. Audio
Sir? இல்ல சார், உங்க ஆடியோ வந்து not clear, sir.
Only my audio is not clear, or everybody's audio is not clear, sir?
Both audio and video.
Sir, so your audio is not clear, sir.
And your video is also not clear.
Video konja lighting the problem, sir, as I said earlier. But your konja voice வந்து break ஆகுது. கொஞ்சம் headphone வந்துட்டு மறுபடியும் reinsert பண்ணி பாருங்க, sir.
Yes, sir. Everybody's voice is breaking. I'm not able to clearly hear the voice, sir.
Sir, headphones இல்லாம பேசி பாருங்க சார்.
இல்ல, அவருக்கு நெட்வொர்க் ப்ராப்ளம் இருக்கு சார். நெட்வொர்க் தான் இஷ்யூ.
சார், இன்டர்நெட் எப்படி சார் இருக்கு விஷ்ணு சார்? Vishnu sir, can you change your headphone or you make it internet on proper, sir?
இல்லனா ரீகனெக்ட் பண்ணிடுங்க சார். மோஸ்ட்லி it will become all right.
YouTuber live ஆயிடுச்சு சார், லைவ் போயிட்டு இருக்கு.
Yes sir, I'm not able to hear.
இப்ப பரவாயில்லை சார்.
இப்போ better.
Okay.
Now it's better. Yeah.
Okay, sir.
I think உங்களோட
start, sir.
Now we can start, sir. PTS sir.
Yes sir.
அஜு நீங்க இருக்கீங்களா?
Yes sir, இருக்கேன் சார்.
ஓகே, நீங்க உங்க வீடியோ ஆன் பண்ணுங்க அஜு. நீங்க உள்ள வந்துருங்க. So it will be easy.
Sir, able to see my screen, sir?
Yes,
yeah.
Yes sir.
Unshare the screen, sir.
Unshare?
இப்போ unshare பண்ணிடுங்க சார்.
We'll introduce பண்ணிட்டு அப்புறம் ஷேர் பண்ணுங்க.
Okay sir, okay. Yes sir, I'm ready, sir.
PTS sir. நீங்க PTS and Thanapan sir, நீங்க you can take over, sir.
PTS sir.
Sir, நான் இப்போ ஃபர்ஸ்ட் இன்ட்ரோ듀ஸ் பண்ணி ஸ்டார்ட் பண்ணிடுறேன் சார்.
ஸ்டார்ட் பண்ணுங்க சார்.
ஓகே. So good evening to everyone. So welcome you all to the 21st program of TNOA PG teaching. So today's topic is clinical case scenarios in spine and interactive section. So today's faculties are Dr. C S Vishnuprasath, Dr. Aju Bosco, and the expert panelist is Professor B Sivakumar. So Professor B Sivakumar is a professor of orthopedics spine, Madurai Medical College, Madurai. So hope everyone knows him very well. He took a class on dorsal-lumbar injuries, 9th program. So regarding our first faculty, Dr. C S Vishnuprasath, he is a secretary of Midwest Orthopedics Society. It's a TNOA affiliated district chapter from Salem. He did his MBBS from Salem Owen Kumaramangalam Medical College in 2004. Did his MS Ortho from PGIMS Rohtak, Haryana in 2009. He finished his F&B spine surgery from Ganga Hospital, Coimbatore in 2013. From 2013 onwards, he is a consultant at SKS Hospital. SKS Hospital is accredited for a F&B spine surgery program by a national board. It's in Salem. So next faculty is Dr. Aju Bosco. He did his MS Ortho, DNB and F&B spine surgery. He is currently Asia Pacific Geographical Representative of Young Surgeons Committee of SICOT. He is a section editor of SICOT newsletter. He is editorial board of Asian Spine Journal and European Spine Journal. Presently, he is doing as assistant professor of orthopedics and spine surgery at Madras Medical College. It's Institute of Orthopedics and Traumatology at Chennai. So to Dr. Thanapan, sir.
Okay, sir. Thank you, sir. So I want to add a few more words about our Professor B Sivakumar, sir. He's my teacher. He's an enigmatic professor from Madurai. He's a Mandin Maindan of Madurai. He's been an examiner all around India for postgraduates, undergraduates, postgraduates, dependee as well as fellowship. So he has a very fast experience in spine surgery as well as in spine clinical examination. So we are very happy to include him in this program as an expert panelist. So with these few introduction words, I hand over the mic to Dr. Vishnu and Dr. Ajay to proceed with the program. You can take over this, sir.
Shall I start sharing the screen, sir?
Yes, sir. Yes, sir.
Able to see my full screen, sir?
To make the screen full, sir.
Is it okay now?
No, sir. You have to start slide sharing. Slideshow. No, you share the screen, sir, and open the PowerPoint and do the slideshow. Yes, sir.
Okay. So I thank TNOA PG teaching program coordinators to give me a chance to discuss a few things with the students. So I will straight away go to the case presentation. Today I will show some present a case, and I will interact with the students, and we will come to a conclusion. So the case, first case is 60-year-old male who is farmer by occupation. So came to our outpatient clinic with the main complaint of difficulty in walking. So the difficulty in walking started 6 months back. So initially he was having difficulty only in the dark. That means when he is getting up to pass urine in the midnight, he is stumbling somewhere and there is an unsteadiness gait. But now gradually progressed. Now even in the daytime he is having unsteady gait. So because of this problem, he is not going out to the work. So he is not able to walk in the uneven surfaces. So he is not going out to the work to work in the farms. But he is able to walk with he is able to walk inside the house without any support. He is also complaining of numbness and clumsiness of hand and foot. He is having a numbness and clumsiness of the foot. Because of this numbness and clumsiness of the hands and foot, he is having difficulty in buttoning the shirt. He is not able to button the shirt. He is taking longer time to button the shirt. And mixing the food, it's whenever he is trying to mix the food and feed himself, there is a scattering of the food. If he is eating some hard foodstuffs, he is not able to tear the dosa and idli. Somebody has to cut into pieces so that he can feed himself. And whenever he is walking with the footwear, over a period of time, footwear slips away without his knowledge. So these are the problems he presented with. But he is also complaining of diffuse neck and back pain. He is also having diffuse neck and vague symptoms of diffuse back and neck pain. But the bladder and the bowel habits are normal. Sir, do we have any postgraduates with us now, sir?
You can ask Dr. Suresh, Dr. Senthil or Dr. Mahesh.
Okay, Senthil, Mahesh, you are there?
Dr. Ramesh sir, please unmute Dr. Senthil from Madurai and Dr. Mahesh Babu from Madurai.
Okay, sir. Okay, sir.
Dr. Guna and Dr. Narendran also from KMC are available, sir. You can call them.
அவங்க 4 பேரையும் நீங்க அன்மியூட் பண்ணிருங்க சார்.
குணா and Narendran. அப்புறம் MMC ல 2 பேர் போட்டு இன்க்ளூட் பண்ணிருக்கோம் சார்.
Dr. Bhunesh, sir. Bhunesh and Dr.
Yeah, Bhunesh. Dinesh.
6 பேரையும் அன்மியூட் பண்ணுங்க சார்.
Yes, sir. Sir, Senthil from Madurai. அப்புறம் சார்
மகேஷ் பாபு from Madurai. Chat boxல போடுங்க. அந்த 6 பேரும் chat boxல அன்மியூட் பண்ண சொல்லி போடுங்க.
The concerned PGs, please send a message in chat box to unmute yourself.
Already Senthil போட்டிருக்கார் சார். நரேந்திரன் போட்டிருக்காரு. குணா Magesh Marimuthu from Madurai.
Hello, sir.
Sandil is unmuted, sir. Vishnu sir, you can ask questions. Vishnu sir. Vishnu sir. Vishnu sir.
Vishnu sir, now you can unmute. Vishnu sir, you can unmute now.
Yourself and
Yes.
Okay. PGs, Sendal, Magesh, are there?
Yes, sir.
Yes, sir.
Yes, sir.
Okay. Okay. I think you have heard the history.
Yes, sir.
Yes, sir.
Farmer who presented with difficulty in walking. There is some sort of gait unsteadiness,
Okay, sir.
because of which he is not able to go to the work. Okay, one thing. Second, he is also having numbness, clumsiness of the hands and foot. So he is having that sort of symptom also, and because of that he is having difficulty in doing some fine things with the hand, making food, buttoning the shirt. So he is not able to do that.
Okay.
When he is walking, the footwear, the footwear are slipping out, and he is not able to hold the footwear tightly. Okay. Vague neck and back pain. Not significant, mild pain is there.
Okay.
So this is a presenting symptom. So do you want to ask anything else in the history?
So any history of trauma, sir?
Any history of trauma? There is no history of trauma.
Okay, sir. Sir, the difficulty in vision initially in the night time and later it has progressed in the daytime also.
Okay, so initially it was in the night. Darkness is not able to walk. There is unsteadiness. Now even in the good vision, good daylight also is having a difficulty in walking. Some unsteadiness is there.
Okay, sir.
Okay. So what else do you want? Is there anything else you want to know? Or is there, do you want to know any other negative histories?
Sir,
so which comorbidities can cause this sort of symptoms? Comorbidities.
Patient having any.
Sir,
Yes, ma'am.
we should ask any history of early morning stiffness.
Yes, sir.
Early morning stiffness.
Yes, sir.
Okay, so generally he's saying that உடம்பெல்லாம் ரொம்ப டைட்டா இருக்க மாதிரி அப்படின்னு சொல்றாரு, but it's not happened to the early morning. It's throughout the day.
Any history of small muscle wasting in the hands?
Any history of
muscle wasting in the hands?
Muscle wasting in the hands. So he's not able to. History is not saying, but he's saying that he's not able to do fine things, and he's having some difficulty in holding the things also, tightly holding the things. Things they used to tend to slip away from the hand. That is also happening.
Okay.
So this is the scenario. Okay. So I will go to the negative history. There is no history of trauma. There is no history of systemic features like fever, loss of weight, loss of appetite is not there. Patient is not a known diabetic patient. He is an alcoholic, not a smoker. He is a village farmer who was doing hard. Now for the past, he is not able to walk. And when I am asking the questions, he is able to answer my question well, and he is able to understand my questions well. So what do you think? Is there any other history you want to ask in this patient? So to summarize, okay.
Yes, sir.
So the patient is having a progressive gait disturbance. Okay, one thing.
Okay, sir.
Second thing, patient's both upper and lower limb is involved.
Okay.
Lower limb in the form of gait disturbance, upper limb in the form of clumsiness of the hand and difficulty in things. Two things.
Okay, sir.
But his speech and orientation is normal from the history. He's able to understand my question and he's able to answer. This is this thing. Upper limb involvement is there, lower limb involvement is there, speech and orientation is normal. What can cause this? What can cause this?
So any upper motor neuron lesion can start.
Any upper motor neuron lesion can cause. So what will be the anatomical site? What will be the anatomical site of this upper motor neuron lesion, do you think?
Upper limb is in. So which do you think? Dr. Vishnu's question is, upper motor neuron lesion can be in the brain, can be in the spinal cord. So which do you think is the site from the history? That is what Dr. Vishnu said.
R has already given the history of neck pain and back pain.
The pathology could be in the cervical spine and spinal canal, spinal cord of upper cervical spine.
So who is that?
Sendil.
Sendil. Okay, so you are suspecting there is some sort of cord involvement in the cervical spine.
Cervical spine. Yes, sir.
Why? Because there is both upper and lower limb involvement is there.
Both upper limb and lower limb involvement, progressive gait disturbance, and clumsiness of hands in the upper limb, and chronic neck pain and back pain. The patient has admitted in the history, sir.
Okay. So
since speech and orientation is normal, the pathology in the brain or above the level of spinal cord can be excluded, sir.
Very good. So what pathology in the brain can cause this sort of gait disturbance? Most common pathology in the brain can cause this sort of disturbance. Unsteadiness, orientation is lost. Which part of the brain is involved? Very good. Parkinson disease.
Parkinson disease.
That can be there. One thing. Second thing is, which part of the brain is for balancing?
Cerebellar.
Okay. So in cerebellar,
degeneration can.
Degeneration. Okay. Cerebellum and Parkinson. What will the speech will be normal or not?
No, sir. Speech will be shattered. Speech will be present in Parkinson.
Excellent. Parkinson disease speech will be abnormal. In cerebral also there will be slackening of the speech will be there. Here the speech is normal. So that is excluded. So you are thinking cervical spine.
Okay.
What about your peripheral neuropathies? For example, the patient is diabetic neuropathy or some other sensory neuropathy. Patient will have numbness.
Patient will have numbness, but it will be related to a particular dermatomal of particular nerves. Here both.
Okay. If it is a generalized neuropathy involving both upper and lower limb, can it cause kind of symptoms or not?
Okay.
So the patient is having gait disturbance.
Okay, sir.
Upper limb and lower limb involvement is there. The sensation is decreased. Can it or not? Is there a possibility or not?
Sorry, sir. No idea.
Okay. There is possibility. Okay. So this kind of upper and lower limb involvement can be because of central cause. So cerebral ataxia or Parkinson disease, but speech will be normal speech will not be normal in this case. Second is spinal cord can be compressed. So if both are upper and lower limb involved, the anatomical lesion should be in the cervical spine. Okay.
Cervical spine. Okay.
What are the causes of compression in cervical spine?
So it can be extradural, extramedullary or intramedullary, sir. Patient can have cervical spondylosis.
Very good. So what is degeneration can cause cervical cord compression?
Degenerative. Okay, sir. Intradural
any infections.
Patient
any infection,
meningitis, abscess, tumor.
Tumor can cause this thing. So broadly classified into degeneration, infection, and tumor. So what do you think this belongs to? Degeneration, infection, or tumor? From the history.
Patient, we can rule out infections since patient has no history of fever or toxic symptoms is not there, so we can rule out infection.
Rule out infection. Okay.
Okay, sir.
Tumor. So going back to the history, patient was vague, diffuse neck and back pain. The pain was not specific. Okay. If the patient is having significant neck pain, then we can suspect something happening in the cervical spine. But if the patient is not having very significant pain in the anatomical location, we can rule out tumor and infection.
Okay.
Yeah,
Okay, sir. Since he's a farmer by occupation, sir, it can be a ependymoma, astrocytoma.
Could be there. Could be there. It could
sir.
be a rare possibility where the pain is
spinal cord
and the patient is having myelopathic symptoms. So the most common would be compression out of degeneration. Cervical spondylosis compression will be the most common because of the age. Second, because of the pain is non-specific and vague complaints of pain is there.
Okay, sir.
Tumor, we can keep it less because the pain is not very significant. Okay. There can be non-compressive myelopathies also, but we will look into the later. Third is peripheral neuropathies. Peripheral neuropathies can also cause these kind of symptoms.
Okay, sir.
Like numbness, clumsiness. Why the patient should have an unsteady gait? You are saying that it's a cervical cord compression. Why the patient should have an unsteady gait in cervical cord compression?
Patient having gait disturbance because the tone of the muscles become increased. There will be hypertonia and there will be class like spasticity will be present.
Okay,
so which will contribute to gait disturbance.
Okay, there was a clue in the patient was having much significant unsteadiness. In the daytime, he was able to walk. So the presence of light is having also a factor. What do you have some clue with that? In the dark, he is not able to walk normally. In the daytime, initially, he was able to walk normally in the daytime.
Okay, sir.
Pick up the clue there. So what is this proprioception, position sensation? So when you are walking, do you look into the foot? Or
posterior.
When you are walking, do you walk looking into your feet or do you walk straight?
We look straight, sir, doing walking.
Why? Because even without looking into the foot, you know where
the proprioception acts.
Yes, okay. So because of loss of proprioception, they are not able to walk. So they have to watch their So they have to watch their foot. So whenever there is a condition loss of proprioception, there will be gait unsteadiness. So cervical myelopathy also the cause of unsteadiness is loss of proprioception. The same can happen in peripheral neuropathy also. So you should peripheral neuropathy in your differential diagnosis.
Okay.
So ruled out the central cause because speech is normal. So cervical spine should be involved. Causes cervical degeneration and peripheral neuropathy. We should keep it in the mind. So this is what we have got from the history. So now
sir.
to the clinical examination.
Okay, sir.
So the clinical examination, there is we have to examine the patient. First is central nervous system examination, higher mental function and cranial nerves. This case, higher mental function is normal. We are taking granted from the history. So we have to start from the gait, motor system examination, reflexes and specific examination. I will show you a video. Okay. Then you comment on the gait.
Okay, sir. Gait எல்லாம் எப்படி சார் சொல்றது?
கண்டிப்பா சொல்லி தான் பார்க்கணும். Able to see the video?
Sir,
yes, sir. Yes, sir.
Okay.
Yes, sir.
Okay. So this is the gait of the patient. Actually, I have got this video cropped from multiple patients to show you a classical picture. Okay.
Okay, sir.
Okay. So this is the gait of the patient. Just observe him. See how he is walking. See how he is walking. Can you comment on the gait?
Sir,
Just it will be difficult only. It is not a classical gait what you see or you read. Just what you are observing.
So broad-based
Very good, excellent. Broad-based gait.
Broad-based gait, sir.
Why the patient is having broad-based gait?
So since the patient has loss of proprioception,
yes,
he has no idea where his foot is landing.
Yes.
So to avoid collisions, he is making a broad-based gait.
Okay, that's not the reason, because if the gait is broad-based, the stability of the gait improves. Okay. So what is the Romberg sign? When we are making the patient
walking straight.
No, Romberg sign. Romberg sign when the patient is standing straight with
closing his eyes.
Close together. Okay.
Okay,
When the foot is close together.
Okay, sir.
Closes the eye, there is unsteadiness. Okay.
Okay, sir. Okay, sir.
Same. So here, when he is walking with the foot close together, the gait will become more unsteady.
Unsteadiness.
The broad-based gait.
Okay.
Closely, the patient was seeing where he is keeping the foot. Okay, two things. Patient will see the foot, there will be a broad-based gait. Third thing will be, there will be clawing of the toes.
Okay, sir.
Walking, just see my video.
Okay, sir.
Keeping the foot, they will try to catch the floor like this. Okay?
Okay, sir.
With
Okay,
the
sir.
foot. So why it is? Because there is sensation is not there to increase the grip. Okay?
Okay, sir.
They will try to hold the floor. These are the things we have to watch. Broad gait, patient will be seeing the foot and
clawing
they will
of
try to
toes.
clawing of the toes. These are the things the patient you have to observe in the this thing. Okay. So second thing. So what is tandem walk? What is tandem walk? So if the patient, yes. Have you heard about the thing tandem walk?
No, sir.
So here tandem walk means adi மேல அடி வைக்கிறன்னு சொல்றாங்க இல்லையா? A foot
stamping gait.
Yes. I'll just show that. Able to see my slide?
Yes, sir.
Okay, this is the tandem walk. See here, the patient has to keep the foot one above the other, like this.
Other. Okay. Okay, sir.
So here again, if the patient is having an early cervical myelopathy, early stage,
okay, sir.
The patient is not having very much symptoms, then we can diagnose the patient by asking him to walk in a tandem way.
Walking. Okay, sir.
Same way like Romberg's test, patient has to see front, patient should not see the foot, they have to walk slowly in a straight line.
Straight
so
line.
usually if the patient is having cervical myelopathy, they will tumble, sway this way, this way.
Swaying on opposite.
Yes.
Oh,
yes.
each side.
So this will happen. So same like a Romberg's test.
Okay, sir.
So the gait, we are in the gait. So next, what is the
motor examination?
Motor examination starts with
we have to start with the bulk of the muscle, power and
okay
tone.
Bulk, muscle, power and tone. So here the bulk, if there is a chronic they're not using the limbs, there can be
wasting of muscles.
Okay. If in case of cervical cord involvement, okay,
sir.
So all the four limbs are involved.
Yes, sir.
Which wasting will be first to reveal itself? Which muscle will be first to reveal itself?
Sir,
which muscle?
Quadriceps.
No. Dr. Mahesh, Dr. Gunasegar, any idea? You can easily see that. You can easily see that. Which muscle? It's the. So, okay. In which part of the limb, upper limb, the subcutaneous fan is least? Which part of the upper limb?
The small thenar muscle.
Excellent. This is the intrinsic muscles of the hand. Okay, intrinsic muscle of the hand.
Intrinsic muscle.
Subcutaneous fat is very, very thin. So the muscle wasting will reveal itself first in the intrinsic muscle.
Intrinsic. Okay, sir.
So you will see there will be the intrinsic muscle wasting will be there. So that will be there. One thing. So usually bulk tone. What will be the tone? What tone do you expect in this
The tone will be increased. Hypertonia will be present, sir.
Okay, because you are suspecting something like UMN lesion. So in this patient was having mild increase in the tone, both upper and lower limb. There is a much wasting in the hand was there, intensive lacing was there. And on examination of the motor power, grossly, both upper and lower limb muscle power was grossly normal. But just see this. What is that?
Hand grip, sir.
Hand grip
Patient
weak.
not able to hand grip.
Hand grip. So patients grossly the muscle all normal, but only this hand grip is weak.
Lost. Okay, sir.
Okay. So why so? Because so the intrinsic muscles are the
intrinsic muscles of the hand
the first one to get involved, and they are the first one to reveal itself.
Okay, sir.
So the patients in this patient, the gross upper and lower limb muscle power was almost 4 or 5/5, except for the weak finger grip. This is the what motor system examination is revealed.
Okay, sir.
Thing is coming to the sensory examination. Sensory examination, there is no specific dermatomal distribution seen in this patient. Patient is having sensory blunting. Okay, sensory blunting below C5 level.
Okay, sir.
Okay, the gait was a broad-based gait. Motor power examination, the only positive finding is weak hand grip, and there is increased tone. There is the blunting of the sensation.
Sensory blunting below C5 level.
C5 level. Okay.
Okay, sir.
Examination finding. Following which, what we will examine? Okay.
Reflexes, sir.
Reflexes. Okay. We'll go to the dependent reflexes. I will just show you the video. Tell me what the response is. So what reflex I was testing?
So initially biceps reflexes.
Okay, biceps, which muscle we are stimulating?
Biceps brachii muscle.
Brachii. What should be the response?
The biceps muscle will contract and flexion of
elbow. Okay, just see what is happening here. Sorry. What is happening here? Let's observe again. Can you see that? What is happening here? Is the elbow contracting? Some other is contracting.
Finger
is?
Contract flexion.
Flexion
of fingers. Okay, sir.
Flexion of finger is happening. Okay.
Yes, sir.
So biceps you are expecting elbow flexion, but finger flexion is happening.
Inverted biceps reflex is present.
Very good, excellent. See further brachioradialis. So brachioradialis, what response do you expect?
Contraction of brachioradialis and flexion of elbow will be seen.
Yeah, what you are seeing here?
So flexion of fingers is.
Flexion of fingers is happening. Can you see that?
Fingers is happening. Yes, sir.
Inverted brachioradialis. There is a flexion of fingers.
Flexion of fingers. Okay, sir. Inverted brachioradialis. Inverted brachioradialis reflex.
Very good. So you are saying it's inverted biceps and inverted brachioradialis. What do you mean by inverted? What do you mean by inverted? And why it is happening?
Sir, if in a reflex, if we are testing a reflex, if a particular tendon of a muscle is stroked, the particular muscle will contract and its action will be seen, sir. In inverted, if we stroke a particular muscle, that muscle will not contract, and we have seen a reflex somewhere else in the other group of muscles, sir.
Why it is happening? In which condition will happen?
In the case of compressive myelopathy.
Okay, excellent. Compressive myelopathy, inverted will happen. Why it happens in compressive myelopathy? Okay, so you should read that. I will just show you the explanation.
Okay, sir.
See here. So whenever, see, this is the spinal cord. So for biceps, brachioradialis, the center is C5 and C6. Okay.
C6. Okay.
C5 and C6.
Okay, sir.
Whenever there is a compression at the C5, C6 level, what happens? The reflex will get diminished. Okay.
Diminished.
Reflex will get diminished. But there is a cross connection between C5, C6 to the C7. There are some fibers which connect C5 segment and C6 segment to the C7 segment.
C7.
And when you are stimulating C5 and C6, that stimulus will not cause any response at C5, C6 level because it is compressed. But that stimulus will travel through that fibers and will stimulate C7.
C7 fibers. Okay.
C7 will cause finger flexion.
Finger flexion. Okay.
Okay. So if there is a compression at C5, C6 level, you will not have a proper biceps and brachioradialis reflex. Instead, that travels to the C7 and that C7 will cause finger flexion. So that is called as inverted biceps and inverted supinator reflex.
Supinator. Okay, sir.
Okay.
Okay, sir.
Vishnu, sir.
Yeah, Aju.
Yeah, and the name for what Vishnuprasath sir explained is called the spillover phenomenon. Okay.
Okay, sir.
What happens? Yeah, what happens is, as sir said, the particular muscle alone will not contract, or sometimes the muscles distally, because of the cross connection, may contract. Yes, sir. You take over, sir.
Okay. That is called as spillover phenomenon.
Spillover phenomenon. Okay, sir.
Okay. Now it comes to the triceps. Observe the reflex. Now knee jerk. Okay. So what is your comment on the knee jerk and triceps reflex?
It appears exaggerated reflex.
Okay. So why it should be exaggerated?
Sir, the inhibitory
Excellent.
reflexes are lost in UMN lesions, sir. So the reflexes will be usually exaggerated.
Exaggerated in the UMN lesion.
Upper UMN lesions.
Normally, when a muscle is stimulated, the reflex will be very strong.
Okay, sir.
So if it is so, then the coordinated movements, fine movements, we cannot do. So to dampen the reflex, there will be inhibitory signals from the brain.
Brain.
So when there is any cord compression, that inhibitory signals will not reach the muscle, and the reflex will be exaggerated. Will be there. So
okay.
Here comes we have examined the reflexes. So there is an inverted supinator, inverted biceps.
Inverted biceps, exaggerated triceps and knee jerks.
Knee jerk is there.
Okay, sir.
So this is a plantar response. What is the plantar response here?
Sir, extensor response is seen, sir.
Extensor response in the plantar. You can see that greater going up.
Plantar.
So this is a plantar response is there. So with the reflexes, what do you conclude? What will be your conclusion? So there is some spasticity is there. Reflexes are exaggerated. Yes. Plantar extensor.
Yeah, extensor is present, sir. So it's more of upper motor neuron lesions, sir. Compressive myelopathy features are
there. Okay. So we were thinking that cerebral pathology is ruled out. We have got compression of the cervical spine and peripheral neuropathy.
Okay.
Peripheral neuropathy, all the reflex will be absent.
Absent. Okay, sir.
Human sense will not be there. So peripheral neuropathy is ruled out. We are only left with the compression, human lesion in the cervical spine.
Cervical. Okay.
So we have got. So what are the special tests you will do in these cases?
Sir, to look for a human lesion, we have to check for Hoffman sign.
Okay.
Crossed adductor signs, Chaddock sign, inverted radial and brachioradial reflex we have already seen. And
yes. So what are hand myelopathic signs? What are hand myelopathic signs?
Sir, Hoffman sign.
Yes.
Grip and release test of fingers.
Fist sign. Fist sign.
Fist sign. Finger escape sign.
Yes, these are the three classical things of a hand myelopathic signs. So whenever you are suspecting a patient with OPD with an unsteady gait, okay. So you have to screen the path. You will not have time in the OPD. It will be a heavy OPD. So this hand myelopathic signs are easy screening test. Do the Hoffman sign. Ask them to make a fist. So all these signs will help you to diagnose conclusion early. I'll just show you one by one.
Okay.
So this is the Hoffman sign. So what we are doing and what is the response?
Sir, if we flex the distal phalanx of the middle finger, we will observe the flexion of thumb and pincer movement will be observed between thumb and index fingers. In Hoffman's.
Okay, just observe this.
Okay.
Is that flexion or sudden extension of the distal phalanx? See again.
Extension.
So you have to keep the distal phalanx flex and sudden extension.
Sudden extension. Okay. Sir.
So that sudden extension will stimulate C7, and we all know that C7 is a
finger flexors.
Okay? So that is called as Hoffman sign.
Hoffman sign.
The stimulation is sudden extension of the distal phalanx. Okay.
Okay, sir. Okay, sir.
So you will see flexion of the other things. So what is this?
Fist sign, sir.
So I asked the lady to make fist. So now you can see my video. If you ask the patient to make fist, okay, in which position we have to make?
Okay, sir.
Patient has to
elbow extended.
Elbow and elbow should be extended, and the wrist should be kept at the dorsiflex position like this.
Dorsiflexed.
Yes. So in this position, they have to make fist, not like this, only like this. So only in this position,
okay, sir.
You will get fatigue and you will see the response. Not in this position. Okay. So patient should extend the dorsiflex the wrist, and they have to make
wrist.
Okay. In 10 seconds. Normally they say that in 10 seconds they have to make fist, 20 fists. So it should be fast and should be coordinated. In cervical what they will do? They will do incoordinated. One hand will be flexing, other hand will be extending. Second thing, they will not be able to flex it fully because of the intrinsic muscle weakness. Just see this. Can you see that patient is not able to extend fully? So this is called a fist sign.
Okay, sir.
Easy sign to analyze in the outpatient department. Third is the finger escape sign.
Okay.
So we ask the patient to keep all the fingers close together.
Adducted.
Keep it adducted. So the patient should be able to hold it like this.
Little finger.
When there is intrinsic muscle weakness, what happens? This little finger.
The little finger and ring finger will get abducted and go for flexion, sir.
Yes, they will drift away.
Okay, sir.
This patient, see the little finger drifting away. So this is called as finger escape sign. There are
finger escape signs.
Yes, Hoffman sign,
finger escape sign, and fist sign.
So these are the things you should remember. Okay. So we have come to a conclusion. So from the history, the patient was having progressive gait disturbance, both upper and lower involvement. Speech orientation was normal. So from the history, we have ruled out the central cause for unsteady gait. We are having peripheral neuropathy and spinal cord compression. So we have ruled out the peripheral neuropathies because patient is having exaggerated reflexes and human signs. So we have just just left with the spinal cord involvement, the two in cervical
compression. Okay.
Yes. So what will be your diagnosis? How will you say the diagnosis?
Sir, it's the pathology has been confined to the upper cervical level lesion.
Okay.
Either due to mainly due to compression of the spinal canal in the upper cervical region, either mainly due to degeneration of the.
Okay. So what is the diagnosis? What is the clinical diagnosis?
Cervical compressive myelopathy.
Yes, cervical compressive myelopathy. Okay. What will be the probable cause of it? Secondary to?
Degeneration.
What is the degeneration cervical spine? What do you call it as?
Cervical
spondylosis.
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 Okay. Cervical compressive myelopathy Most
Secondary.
secondary to cervical spondylotic compression.
Okay, sir.
Okay, so that will be your provisional diagnosis. Cervical myelopathy, most probably secondary to cervical spondylotic compression. This will be provisional diagnosis. So, what investigations you will ask?
I will go for a radiological investigation of X-ray cervical spine, AP lateral, and both in flexion and extension views.
Okay.
Next, we can go for any CT scan of cervical spine.
Okay.
And then we can out for a MRI of cervical spine.
Okay, your order of investigation is completely wrong.
Okay, sir.
Okay? So you are suspecting a cervical compressive myelopathy.
Okay, sir.
So where is the compression? In the spinal cord. Which imaging modality you will see the spinal cord?
In MRI, sir.
Okay. So, so the traditional teaching will be you should first get the X-ray done, then CT scan, then MRI, nothing like that. In cervical myelopathy, if you are suspecting cervical myelopathy strongly, the first choice should be
MRI.
MRI. Might be old time examiners, they will not accept this. But in clinical scenario, in your exam outpatient department, if you are seeing this patient with cervical myelopathy, you should order MRI first.
Okay, sir.
X-ray, you can just see the X-ray and send them home. Are you going to ask them to come and ready after 1 month? No. If you are suspecting cervical myelopathy,
okay, sir.
Cervical spondylotic myelopathy is a progressive disorder.
Yes, sir.
It is not going to resolve. It's not like a disc prolapse, cervical disc prolapse. It will resolve. Cervical is not going to resolve. It is going to progress. If you delay your investigations, you are doing injustice to the patient. So the first investigation should be MRI.
MRI. Okay, sir.
MRI. Okay. But
Vishnu sir.
Yes,
sorry
sir.
to interrupt. Sorry, a small. How will you differentiate syrinx or syringomyelia from, for the benefit of PGs, when you have a similar complaint? No, sometimes you might have a syringomyelia. So can you just give them the differential points for syringomyelia and cord compression also and myelopathy?
Yes, sir. We are coming down to the last things, the differential diagnosis in the MRI and all those things.
Okay.
Yes, sir. Yes. Thank you, sir. So these are the things we have to say. So investigations, since you said X-ray first, so this is the X-ray of the patient. Okay. Can you see that X-ray?
Sir, it's a plain X-ray of cervical spine lateral view.
Yes.
Actually, the cervical lordosis is actually maintained in the.
Yes, very good. First thing is lordosis maintained. Second
thing. Disc space or maintained in this cervical
disc space is maintained. Second thing. Third thing.
Okay, sir.
Fast.
End osteophytes is seen in.
Yes, this is the first thing you should say. Okay. C2, C3, the alignment of the cervical spine is normal. First thing. Lordosis maintained.
Okay, sir.
Yeah. Cervical spondylosis. Osteophytes.
Osteophytes.
So we are thinking in terms of cervical spondylotic cord compression. You are seeing a positive finding. There is cervical spondylosis seen. So that you should say first, and lordosis maintained. So what are the things, other things we have to see in the X-ray? First thing is alignment. So this is the anterior vertebral body line, posterior vertebral body line, and this is the spinolaminar line. This one,
spinolaminar line.
Posterior spinous line.
Posterior spine.
We have to, whenever there is a cervical spine injury, we have to all these things. But even in cervical myelopathy or degenerative condition, we have to see these lines. This will help us in decide the surgery. So I'm taking too much of
this.
Rush it. So first thing is alignment. You are saying about the alignment. Okay. So this is the lordotic. What is this alignment?
Yes, sir.
What is this? Lordosis is maintained or not?
So lordosis is lost.
Loss. There is a
loss of lordosis is in there.
Yes, there is cervical kyphosis is there. Okay. One thing first
kyphosis
thing
is present.
Lordotic or kyphosis is there. Third thing, instability.
Kyphosis.
Yes.
Instability.
So not kyphosis.
Okay.
Listhesis. You said flexion extension view. These kind of flexion extension view we will take only when you are taking the patient for the surgery to decide what surgery you are going to do. Okay. What is the initial investigation?
Okay, sir.
Third is ossified posterior longitudinal ligament. What is that?
Posterior OPLL. Oh, okay, sir.
Oh, OPLL. There is OPLL.
The posterior longitudinal ligament. Oh, yes, sir.
Gets ossified and it can also compress the cord.
Compress the spinal canal.
Yes,
Okay.
not only the cervical spondylosis, ossified posterior longitudinal ligament can also compress the cord. So you usually this can reduce the OPLL, but in X-ray also, if you see clearly, can you see that this is the C2 vertebra? Can you see the posterior vertebral body line here?
Yes, sir.
Okay, can you just follow it.
Yes, sir.
Can you see that there is an increased density here?
Density. Okay, sir.
Yes, yes. So whenever you are seeing a patient of cervical myelopathy, you should look into these features. Okay.
Ossified posterior longitudinal. Okay, sir.
So these are the things we have to see. So here the patient's lordosis is maintained, cervical spondylotic changes are seen, and we are not seeing OPLL. So these are things we have to see in the cervical spine. Okay, this cervical spine is over. So now what else? We have the MRI scan. Can you just read this MRI scan of this patient?
Yes, sir. It's T1 weighted image of MRI cervical spine. Showing multi-level cord.
T1 or T2 weighted image? In T2, H2O. T2, water will be white. Here, the CSF is white. So what do you
think? CSF is white. Okay.
Yes. So it is T1
so
or
T2
T2
weighted image.
Very good. T2 weighted image.
T2.
Yes.
Okay, sir.
Okay.
Showing multi-level cord compression at the level of C3, C4, C5, C4, C5, and C5, C6, and also in C6, C7, sir.
Very good. So what do you think is the etiology of this compression? What structure is causing compression here?
Disc prolapse.
Prolapse.
Intervertebral disc is causing prolapse is causing compression.
So see here, this is a vertebral body. This is a vertebral body. This is a disc. Okay, disc prolapse which should come out and compress the cord. Do you see any disc coming out and compressing the cord? Is there any particular term we can use?
No, sir.
Not disc.
So X-ray we are seeing something. What was the positive finding in the X-ray?
Osteophytes were present.
So do you think osteophytes will be present only anteriorly or posteriorly also it can happen?
Posterior osteophytes can also present.
X-ray we will not see that, but there will be osteophytes posteriorly.
Okay, sir.
Posterior osteophytes along with some mild disc. We call it as disc osteophyte complex. Okay.
Disc osteophyte complex. Okay,
disc
sir.
osteophyte complex.
Complex. Okay, sir.
So posteriorly, so see here, okay. Anterior also there is a compression. Posterior also there is a compression.
Yes, sir.
We have got disc osteophyte complex. Posterior, what is the structure compressing the cord?
Maybe facet joint hypertrophy, ligamentum flavum.
Yes, very good. Ligamentum flavum.
Ligamentum flavum hypertrophy, buckling of ligamentum flavum.
Excellent, excellent. Buckling of the ligamentum flavum. Very good. So there is anteriorly there is a disc osteophyte complex. Posteriorly there is a buckling of the ligamentum flavum. So both compressing the cord. So what is the etiology here? Cervical spondylotic compression.
Compressive mode. Okay, sir.
Cervical spondylotic
compressive
myelopathy. Okay. So what other things we have to see in the MRI? I will just go through it. So what is the severity of the compression? You see here, left hand side, there is only very mild compression is there. Here, mild to moderate compression. Here there is mild to moderate compression. As we come down, C5, C6, C7, there is very severe compression is there.
Yes, sir.
Very severe. So how severe the compression is, we have to look. Second thing, from where the compression is. Can you just say from where the compression is here? First picture.
Sir, between C1, C2's level, sir.
C1 is here. This is C2, this is C3.
C2, sorry, sir. C2, C3 level, sir.
Okay, from anterior, the compression is there. Okay. The compression here is only from the anterior aspect here. Okay.
From anterior aspect.
Here,
okay, sir.
Our patient, it is both from the
anterior and posterior.
Can you see that here?
Yes.
It's predominantly from anterior or posterior?
From the posteriors.
Posterior. So here, predominantly from the anterior.
Anterior.
Here,
both anterior and
posterior. Here, predominantly from the posterior.
Posterior side.
Okay. So what is the structure causing the compression in the first picture? Structure. See here, there is an anterior compression here. This is the level.
Yes,
This is the level of the disc. You are seeing compression above the level of the disc.
Superior migration of
Osteoid posterior long.
Yes, excellent. Magesh?
Osteoid posterior long-term ligament.
Excellent, excellent, excellent. You can see here, this is the vertebral body. This is the disc. Can you see the black line here? This is the posterior longitudinal ligament.
Yes, sir.
Okay. Whenever you are seeing a compression behind the vertebral body, so this is the disc space. When the compression at the disc space, you can attribute the compression to the disc. But when the compression is at the level of the body, vertebral body,
okay, sir,
there will be a superior migration of disc in cervical spine. Unlike lumbar spine. Lumbar spine, superior inferior migration is common, but in cervical spine, usually the disc loss will be very less and superior migration, inferior migration hard to happen. So
okay, sir.
Because of the ossified
posterior longitudinal ligament.
Yes.
Okay, sir.
Yes. So again, this is structure causing compression. I already told you. Alignment of the spine. This is lordotic. This is a
kyphotic.
So levels of compression. How many levels are compressed here? See here.
Sir, in the single level compression.
Single level. Here.
Level. Both 2 levels.
2 levels. Here.
Multi-level compression.
Multi-level. All these things are very important. How many levels are compressed? From where the compression is coming, and severity of the compression, alignment of the spine. This
okay, sir.
You should know to treat the patient. Okay.
Okay, sir.
Okay. Now, most important thing, what is that? So usually there is the cord in a T2 weighted image.
Signal intensity will be increased in T2 weighted image, sir.
Yes, very good. Normally it will be a dark signal intensity.
Hyper intensity will be seen.
Okay. There is a whitish signal intensity, hyper intensity in the
okay.
T2 image. What does it mean?
T2 weighted image.
So in T2, the cord should be black. Which thing will be white in T2?
In H2O water.
Yes, water. So if there is any edema, it will be white.
Edema, cord edema will.
Yes, edema. And if there is any compression causing myelomalacia also.
Myelomalacia.
It will be white.
Okay, sir.
Okay. Also, whenever you are sending the patient, always ask to get an 1.5 Tesla MRI with whole spine screening. 0.5 Tesla, 0.2 Tesla will not help, and we should always get whole spine MRI. Can you see that? Here there is a cervical cord compression is there, and also there is a thoracic cord compression is there. Sir. There is a lumbar stenosis.
Lumbar canal.
Stenosis also there. So for PGs who are made Dharmaburi Medical College and Salem Medical College, thus ossified posterior longitudinal ligament, ossified yellow causing thoracic myelopathy is very common in Dharmaburi Krishnagiri region. So I used to practice there. I am seeing a lot of patients. You should be very cautious. You should always do whole spine screening in these cases. This thing. So this is the MRI. So what will be the final diagnosis?
Cervical myelopathy secondary to cervical spondylotic compression.
Okay.
From C4, C5 to C6, C7, C6,
level.
C7 level.
C7 level. There is a compression, and you have to tell about the neurology also. So neurology, commonly we use a Neurix.
Neurix grading, sir.
Neurix grading. What is the Neurix grading?
Sir, in grade 0, signs and symptoms will be present, but cord compression symptoms will be absent, sir. Next, sign of cord involvement.
That is grade 1. That is grade 1. Okay, the patient, if you are examining, UMN signs will be there. But still that patient will not have any symptoms. That is grade 1. Second is?
Mild gait involvement will be present, but patient will be able to go for his work. He will be employed, sir.
Next grade, able to do normal. Okay, grade 4.
Gait abnormality will present. Gait abnormality will present, which is preventing his employment, but he can able to do his household works, sir.
Okay.
Grade 4 is can able to ambulate only with support of some assistance, sir. Grade 5 is he is completely bedridden, non-ambulant.
Oh, non-ambulant. So in which category our patient will come?
So grade
3.
He is not employed. So he is not going for work, but he is working in his home. So grade 3 will be present.
Grade 3 will be the Neurix grade 3. So diagnosis will be cervical myelopathy, secondary to cervical spondylotic compression from C4 to C6 level with Neurix grade 3 neurology.
Okay, sir.
Sir, excuse me, sir. So do we have time for another 5 minutes so that finish the treatment part?
We can ask the expert to comment about this case so far.
Yes, sir. Yes, sir. Yes, sir. I will pass.
Can give his inputs. Sokmar,
Yes,
sir. Sokmar, sir. Sir, you unmute, sir. Sokmar, sir, you unmute yourself and talk.
Sir, BSK sir, நீங்க unmute பண்ணுங்க sir. அந்த ஸ்பேஸ் பார் தட்டுங்க சார், ஸ்பேஸ் பார் கம்ப்யூட்டர்னா ஸ்பேஸ் பார் தட்டுங்க சார். அமுத்தி புடிச்சுக்கோங்க சார் அப்படியே ஸ்பேஸ் பார்.
நீங்க இல்ல சார் அன்மியூட்
இல்ல நீங்க ஸ்பேஸ் பார் அமுத்தி புடிச்சுக்கணும் சார். யூ ஜஸ்ட் ஹோல்ட் இட். Yes sir, இப்ப பேசுங்க சார். Yes sir. Yes.
So it's a very interesting case and this is cervical myelopathy is nowadays not only for degeneration but also our as he said, not only in Dharmabari near Madurai also because of this fluorosis presenting as ossified posterior longitudinal ligament. We are getting a lot of OPLL and also ligamentum flavum calcification leading on to these myelopathic changes. So it's very, very common. And one thing in the history I like to ask the patient has a tremor. So that differentiate from the cerebellar lesion, Parkinsonism to also to the cervical myelopathy also. Cervical myelopathy patients will usually don't have any tremor. That's one point which I like to add in this case. He said everything about this very good clinical science. Everything he has told. Everything is thorough. There is no addition for that. And CT will be very helpful in case to find out the ossified posterior longitudinal ligament. It will be very helpful and more useful than MRI to see that cord compression.
Yes, sir. Yes, sir. So nowadays, what we are doing is when you are suspecting cervical myelopathy, when they are taking MRI scan, they are doing a screening CT also.
Yes,
so
yes. Okay.
Surgical decision making, we are using both CT scan and MRI to make a surgical decision.
Sir, you can proceed and you can go for another 5 minutes, sir.
Yes, okay. Sir. Yes, sir. I will wind up in another 5 minutes, sir.
I think you can give the lecture. You need not ask question. I think you can give.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. I will do that, sir. Okay. So coming to the surgical part. So I said that surgery we can do an anterior surgery or a posterior surgery. So I can when we can do an anterior surgery.
Sorry,
whenever there is a predominant anterior compression or when there is a single level compression, anterior surgery is preferred. So what are the anterior surgery? We have anterior cervical discectomy or anterior cervical corpectomy. Posterior surgery, predominant posterior compression or multi-level compression. So we have to do posterior cervical laminectomy or laminoplasty or laminectomy with instrumentation. These are the options available. So you can see here, so this is a cervical spondylotic myelopathy, C5, C6 level, there is a disc prolapse. Predominant anterior compression, only single level compression, what we have to do? We have to do an anterior cervical discectomy. Yes. So what is the phenomenon behind cervical? Why we have to see alignment of the spine in posterior surgery? So in our case, it is a cervical spondylotic myelopathy. Only when there is a lordosis is maintained, we can go for posterior surgery. See here, so this is a cervical spine with compression. What laminectomy? What we will do? We will remove the lamina. Once the lordosis is maintained, this cord will fall back. Okay. When you are doing a laminectomy, the cord should come back. It should expand. But when the alignment of the cervical spine is kyphotic like this, the cord will not fall back. So doing a posterior surgery in a kyphotic spine will not help the patient. You should keep that in mind. You can see here. So this is a lordotic spine, cervical spondylotic myelopathy. We have done a cervical laminectomy from C3 to C6. The cord has expanded well. So it's called a selective laminectomy. So usually in doing a selective laminectomy, preserving the muscle attachment of C2 and C7 is very, very important. Because most of the main muscles are attached to the C2 and C7 lamina. When you do a C2 and C7 laminectomy, what happens? The muscle attachment is lost, and over a period of time, the cervical lordosis will turn into cervical kyphosis. So when you have to do a C2 and C7 laminectomy, you have to instrument the patient. So see here, this is a patient with a kyphotic segment. Okay. So when you are doing cervical laminectomy, we have to correct the alignment. So what we have done? We have done a cervical laminectomy with screw fixation, so that we are regaining the lordotic spine, so that the cord can fall back. This is called correcting the kyphotic segment. So usually when you are doing a laminectomy, multiple level laminectomy, there is a loss of parasitical attachment is there, and post-operatively progressive kyphosis and instability is a concern. So usually nowadays many surgeons are preferring laminoplasty or instrumentation. But still I will tell that simple laminectomy from C3 to C6 will solve most of the problems. But we can do a laminoplasty wherein we are not doing a laminectomy, just lifting the lamina and fixing, giving some space for the cord to expand. That is called as laminoplasty. You can refer the books. So that comes to the conclusion. Sir was asking how the students should differentiate between a syrinx and this thing. Usually in syrinx, patient will have a dissociative sensory loss will be there. In syrinx, pain will be there, and hardly the patient will have a significant UMS symptoms. There will be muscle wasting will be there, the reflex will be lost. In case of cervical spondylotic myelopathy, the cord compression is there, the UMS symptoms will be predominant. And in the WhatsApp group, I will send you the differentiating features. Thank you, sir. Thank you for the opportunity.
Thank you, sir. Thank you so much.
Thank you.
Thank you, sir. Syrinx, because the short case, normally they keep as a short case in
Yes,
syrinx, syringomyelia. That's why I wanted them to know the difference.
Okay, sir.
Yes, sir. You can put it in the group, sir. They will read that.
Yes, yes.
Thank you, sir. Thank you, sir. It's an excellent,
Thank you, Aju.
very rare topic, covered excellently and in a short period of time. We will move on to class, sir. Next topic, Dr. Aju.
And Dr. Sendil did very well, sir.
Yeah,
Sir, Sendil வந்து இப்பவே I think examiner வந்து pass கொடுத்தலாம் நினைக்கிறேன் சார். இப்பவே கொடுத்துடலாம். He did very well.
Thank you, sir.
Sendil, well done, well done. Yeah.
You unmute you show your video so that everybody can see your face.
You know, it's not a very commonly taken topic. I think Madurai இருக்கிறதுனாலயா என்னன்னு தெரியல. He's done very well, sir. He's more of a neurological examination, but he did well.
You can start, sir.
Aju, நீங்க ரெடியா இருக்கீங்களா?
Unmute பண்ணிக்கோங்க சார். Unmute பண்ணுங்க. So you unmute yourself.
Sir is also not there, and
Sir, can you hear me?
Now you can hear
me. Yes, sir. I'll share screen. Sir, it is coming as disabled participant sharing.
Yeah, so now, sir, you can share, sir, because your name was something else, sir. That's why I have not given you the right.
Yeah. Okay. Yeah. Can you see my slides?
Yes, sir.
Yeah.
Yes.
So, first of all, I would like to thank Tamil Nadu Orthopedic Association and all its esteemed members, the President, Thiru sir, Thanapan sir, Professor Sivakumar sir, PT Saravanan sir, for this wonderful opportunity. So I'll go into the topic straight away. I'm not going to present the clinical examination of a case of lumbar spine in the traditional way, because Professor Nalli Viraj sir, Professor Sivakumar sir, and Professor Raj Shekharan, everyone has already spoken. So what I'm going to do is I'm going to highlight only 10 or 15 key issues where postgraduates, even when I was a postgraduate, felt it is difficult, and commonly they made these errors and found it difficult to clear the examination. So I'll highlight those aspects and I'll say how to rectify them. So as Einstein said, anyone who has never made a mistake has never tried anything new. Some of the best lessons we ever learn from our mistakes and failures. The error of the past is the wisdom and success of the future. As surgeons, we all know that a best surgeon evolves with time, making a lot of mistakes and prevents making them, and he learns from his mistakes. So what are the key points in history when you present a case of lumbar spine? So we are going to have two common cases. One is a low back pain with a radiculopathy, and the other is a lumbar canal stenosis or lumbar spinal stenosis, we can say. So first of all, both these will present with back pain, and back pain may be spondylogenic or non-spondylogenic back pain. And spondylogenic back pain is what we are interested in, though non-spondylogenic back pain is important to be ruled out. Spondylogenic pain may be a discogenic pain, which arises from the intervertebral disc or the annulus, or it may be a neurogenic pain due to irritation of the nerve roots, whereas a non-spondylogenic pain may be from the viscera or from vascular structures like the abdominal aorta. So back pain, low back pain is a Pandora's box. Pandora's box is a box which when opened gives a lot of trouble and confusion according to Greek mythology. But I've simplified it. We can classify low back pain into 5 common boxes or 5 boxes of presentation. So the diagnosis will definitely fit in any one of these boxes. If the postgraduate knows how to categorize the back pain, then he already has the diagnosis. The first is the common mechanical back pain. It is due to mechanical dysfunction of the spine. It is aggravated by activities and relieved by rest. The patient will say, I had the pain when I am lifting, I have the pain when I am lifting weights, when I am walking, or when I am bending down, and on rest I don't have pain, on lying down I don't have pain. This is typical of mechanical back pain. The second is a discogenic pain. It can be due to degenerative disc disease or due to annular tear. This is aggravated typically by prolonged sitting or flexion posture. It may radiate to the sacroiliac joint or buttock. The third most important pain is the instability type of back pain. Instability type of back pain is a very common case kept in the exam. It may be due to a lumbar facet syndrome, which is not commonly kept, but a spondylolysis or listhesis case is commonly kept. This is typically aggravated by extension of the spine. That is, in postures, when you stand, the spine is extended. When you are getting downstairs, the spine is in extended position. Or when you are lying down, the spine is in an extended position. The patient typically says, I have difficulty turning in bed and getting out of bed early in the morning, or getting up from a sitting position. He gets a catchy pain in the back. The other is the inflammatory back pain. Pain which is typically seen in the morning, relieved after a brief period of activity, typically relieved after a brief period of activity. It is seen in inflammatory arthropathies and typified by ankylosing spondylitis. Next one is the malignant back pain. It is a constant, unremitting pain, not related to any physical activity. By this, I mean that the pain is present at all times, all over the day, and there is also rest pain, and typically, like in a hip disease, patient can wake up with night pain. This is typical of tumor and infection. Next, the important thing in history is a radicular pain. This is common in, this is the presenting feature of a lumbar disc disease with sciatica. But you should understand that sciatica doesn't mean it is involvement of L4, L5 and S1 nerve roots alone. Their sciatica is the name given to pain along the course of the sciatic nerve, which is commonly arises from the L4, 5 and S1 roots. Whereas there is another entity called the femoral radiculopathy, which is pain along the course of the femoral nerve. Because a lumbar disc prolapse can arise from any level from L1, L2 disc to L5, S1 disc. So when there is a L2, L3 disc, and you should not ask the patient, is the pain, are you having a posterior thigh pain or a buttock pain radiating down your posterior aspect of the leg into the foot? The patient will definitely say no. On the other hand, the patient himself will say that he is having anterior thigh pain radiating to knee. So this is typical of femoral radiculopathy, which can arise in a L2, L3 disc. Later we'll see which root is involved. I'll come to that later. The next one, most common, 90% of the disc prolapses occur at L4, L5 and S1 levels. And this presents with the pain along the course of the sciatic nerve. I have shown the diagram. If it is involving the L4 root, it will be along the medial aspect of the leg. If it is involving the L5 root, it will radiate from the buttock down to the lateral aspect of the leg to the dorsum of the foot. And if it is from the S1 root, it arises from the buttock and radiates down the posterior thigh, posterior aspect of the leg and to the sole. Sometimes the S1 radiculopathy may present with posterior thigh pain alone. Next, the disc. We have seen the presentation of a disc prolapse. Now we'll come to the most important symptom of a lumbar canal stenosis or a lumbar spinal stenosis, which is claudication. The only clue for diagnosis of a case of lumbar spinal stenosis is this symptom of claudication, because there is a saying, and it is true, that lumbar spinal stenosis will not have much of clinical signs. It will be having a wide range of symptoms, and these are related to the claudicatory pain, which occurs due to ischemia of the nerve roots. So it is a vague and diffuse pain in which runs into the buttock or into the legs. It is usually associated with numbness or paresthesias in the leg and feet. And if it is a severe stenosis, it will be associated with bowel and bladder dysfunction. So this is a classical claudication symptom. Okay. Now, one thing which should not be forgotten is clinical presentation of a cauda equina syndrome. So as you can see in the MRI pictures, there is a huge disc prolapse compressing the cauda equina. The patient presents with back pain and sciatica, which is usually bilateral, but may be unilateral, numbness and weakness of the lower limbs, which is bilateral, saddle anesthesia, numbness in the perineal region, paralysis of the sphincters, which means bowel and bladder disturbance, and importantly, diminished or absent knee and ankle jerks bilaterally. This is the presentation of a cauda equina syndrome. So, claudication symptoms are not always bilateral. Claudication symptoms may be unilateral or may be bilateral. I have shown the picture of the spinal canal, the axial section of MRI, and the central zone, which is blue in color, is the central canal. Whenever the stenosis occurs in the central canal, as seen in the picture on the right, it presents with bilateral symptoms. It can also be a bilateral foraminal or lateral recess stenosis, which can also present with bilateral symptoms. Whereas in a unilateral compression, like a unilateral facet arthropathy, as seen in your picture on your left side, there will be unilateral foraminal stenosis or unilateral lateral recess stenosis, which causes unilateral symptoms of claudication. Next, many postgraduates, they present the spine case directly without going into general examination. So they ask what to see in general examination. Just like in medicine, where you have findings of cyanosis, clubbing, anemia, and lymphadenopathy, edema, we have a lot of features in general examination to see in a spine case. First one is frontal bossing. This is seen in achondroplasia. Achondroplasia is the most common disorder which presents with multi-level lumbar canal stenosis. It can be kept in the exam. Second, low set ears. It is seen in Turner's syndrome. And a high arched palate is seen in Marfan syndrome. Marfan syndrome commonly can present with a spondylolisthesis or with a scoliosis. Low posterior hairline, which is or a webbed neck, is seen in Klippel-Feil syndrome, which can be kept as a spotter. It presents with block vertebra in the cervical spine and can present with cervical spinal stenosis. You have to look for clawing of toes, muscle wasting, and ischemic ulcers. Why clawing of toes is common in chronic lumbar spinal stenosis, which can present with weakness of the foot, wasting of the foot muscles and weakness of foot muscles leading to clawing. The patient will usually complain that he has to grip his slippers. He is finding difficulty in holding his slippers, or he has to claw his toes in an attempt to hold on to the floor to get a grip while walking. And second, you have to look for ischemic ulcers, because claudication is not due to neurogenic causes alone. It can be due to vascular causes also. Then Marfanoid features are features of hypermobility or hyperlaxity of ligaments. The skin is pinchable, and you have the wrist sign where the wrist can be held between the thumb and the little finger. Then you have the Steenberg or the thumb sign, where placing the thumb into the palm of the hand and closing the fingers, you can see the thumb on the other side. The tip of the thumb is visible, and the patient can very often bend forward and touch the floor with the palm of his hand. And there is arachnodactyly and hyperextension of knee and elbow joints. The criteria used to diagnose Marfan syndrome is called Gens criteria. You can refer to that. Then the most common another clinical syndrome is achondroplasia. This is a typical cause of multi-level lumbar canal stenosis as shown in an MRI picture of an achondroplastic spine. Then neurocutaneous markers. These are very important. They are telltale signs that there is some problem inside the spinal cord or the spinal canal or inside the spinal nerves. Café-Outlet spots and the neurofibromas, cutaneous neurofibromas seen in neurofibromatosis, hairy patch in the lumbar region, which is indicative of a diastematomyelia or a tethered cord syndrome, a lipoma in the lumbar region, which is also indicative of tethered cord, and a midline dimple near the natal cleft, which can be seen in tethered, which is seen in tethered cord syndrome, and cutaneous angiomas. More importantly, surgical scars. Very often, patient will not tell in history that I have undergone a previous surgery. So patient will never come out with that. You have to ask the patient and you have to diagnose it that he has undergone a surgery, and only after seeing the midline surgical scar, you will realize that the patient has undergone a previous L4, L5 discectomy or a lumbar spine surgery, which he has not told on history. And always you have to expose the patient judiciously and also modestly to see these signs. You should not expect the patient to say that I am a case of failed back surgery syndrome and I have come for examination, so this is my history. Patient will never come out with these things. And I've had a bad experience in the exam as well. After taking all the history, I found out that there was a surgical scar and the patient had not come out that he had had a discectomy for 5 years before. Then, attitude and gait. What is important in this? It is the spine examination is like mathematics. So 1 + 1 will be 2. So if it is a lumbar canal stenosis, patient will typically present with a stooped forward posture. There is a rationale behind it because the spinal canal always comes to its full volume in flexion, whereas with extension there is buckling of ligamentum flavum and there is impingement on the posterior aspect of the disc, which can bulge into the foramen and the spinal canal. And in extension, the spinal canal is narrowed, aggravating symptoms of spinal stenosis. That's why a forward stooping posture is more comfortable for the patient. Climbing upstairs is more comfortable. Riding a bicycle is more comfortable in a lumbar spinal stenosis patient. Whereas climbing downstairs or lying supine or walking erect is difficult because it extends the spine and further narrows already compromised spinal canal. Whereas a patient with a disc prolapse with radiculopathy is more comfortable on extension. When he flexes forward, the nerve root gets tensed and he has radicular pain. But the most typical presentation of an established radiculopathy is a sciatic list. And this list is important because this itself can give a clue to the diagnosis, whether the location of the disc is in the shoulder of the nerve root or in the axilla of the nerve root. By shoulder, I mean the disc is lateral to the offending nerve, to the nerve which it is offended. So what will happen is the patient will deviate away from the side of the disc prolapse. He will deviate away from the side of disc prolapse for relief of pain. That presents as a sciatic list. Whereas in an axillary disc, the patient will deviate towards the side of the disc prolapse. So this gives a clue to whether the disc is in the shoulder or in the axilla. This is a common question which the examiner can ask. And once the patient is walking to you and he's having a list, you should suspect that he's having a radicular problem. Then this is called Fallon-Dixon sign, which is common in high-grade spondylolisthesis with severe sciatic radiculopathy. Because of the sciatic nerve stretch, the patient adopts a hip flex, knee flex posture. And this is also due to tight hamstrings. The sacrum is vertical and the pelvis is vertical. The lumbar lordosis is exaggerated and the patient has a waddling gait. This is called Fallon-Dixon sign. This is also asked in the exam. Next, gait is very important. Gait is not only important in a case of hip disorder. It is more important in a case of spine disorder. The first gait is a high stepping gait. Whenever the patient is having an L4 radiculopathy with weakness, foot drop can occur due to ankle dorsiflexus weakness. And this manifests as a high stepping or otherwise called a slapping gait. This is due to the inability to hold the foot dorsiflexed. Second is the Trendelenburg gait. This is very, very important, but is often neglected. And this has been the cause for many students to be penalized. Whenever you are suspecting a L5 radiculopathy, don't examine the extensor hallucis longus alone. You have to immediately examine the gluteus medius as well, because it is also supplied by the L5 nerve root. And this gluteus medius weakness, when it is unilateral, can present as a Trendelenburg gait. And when it is bilateral, which is a rare possibility, the patient comes with a waddling gait. And the third one is an antalgic gait. Antalgic gait, why it is important? Whenever a patient is walking into your clinic and he is having an antalgic gait with a short stance phase, mostly it will not be a radiculopathy. And more commonly, it is associated with a hip or a sacroiliac joint pathology. So any condition that causes pain in the lower extremity can produce antalgic gait. But this type of gait is not so common with radiculopathy. Next, key points in palpation. Dr. Professor Nallivaraj has taken all the things, how to palpate, how to look for tenderness, but I am stressing only on one thing, which is frequently asked in the examination. Whenever you come across a case of spondylolisthesis, this is a case which was operated by me. So you can see it has all the findings. You can see a median furrow, which is shown by the yellow arrow. You can see bilateral prominent waist crease shown by the orange arrow. And you can see a step indicated by the blue arrow. This is very important in inspection. And I've zoomed it here. Whenever you have to run your thumb from above downwards along the midline till you reach the step. And the spinous process you palpate gives a clue as to which vertebra has slipped forward. The principle is that in a lytic listhesis, the spinous process is left behind because of the lysis. The vertebra alone moves forward. In this case, there is a L4, L5 lytic listhesis. The red colored spinous process is left behind and the vertebra moves forward. So whenever you are moving your thumb down and reaching the spinous process, the most prominent spinous process will be that of the vertebra below, that of the vertebra above, right? And that offending spinous process is palpated, that is left behind. Whereas in a degenerative listhesis, the spinous process moves forward along with the vertebra. There is no lysis, no discontinuity, and the most prominent spinous process will be the one below the vertebra which has slipped forward. So this is very, very important. Then key points in measurements. These are the 5 important measurements we should not forget: Schober's test, costocrustal distance, arm chest distance, limb length discrepancy, and anthropometry. Each has its own significance. So whenever you are normally measuring the flexion of the lumbar spine, you ask the patient to bend forward, and the amount of distance between the floor and the hand, that is the finger floor distance, is measured. Normally they say the patient should be able to bend forward so that up to within 10 centimeters from the floor. But this is not a true measurement, because the hip joint can compensate to a great extent for a patient who has lumbar spine disease, because whenever you are bending forward, most of the flexion actually occurs at the hip joint. So how will you objectively measure the degree of lumbar spine flexion? Here comes the Schober's and the modified Schober's test. Modified Schober's test is used now. Schober's is for historical importance. In both the tests, you locate the posterior superior iliac spine, that is the dimple of Venus, and you draw a line, horizontal line connecting the dimple of Venus. From the midpoint of that line, along the midline spinous process, you mark 10 centimeter, you mark a point 10 centimeter above the line, and then the patient is asked to bend forward. The distance between the cephalate mark and the proximal mark, it should at least be 15 centimeter or more. But there is a flaw in this test. The level of the dimple of Venus is at the level of the L5S1 junction. So it does not measure the movement happening at the L5S1 lumbosacral junction. Then came the modified Schober test. The modified Schober test takes 2 points. You have to mark the dimple of Venus connected by a horizontal line, mark a point 10 centimeter above the line and another point 5 centimeter below the line. Now you ask the patient to bend forward and measure the distance between the proximal and distal points. Normally it should be more than 5 centimeter. There is a lot of confusion among postgraduates when examiner asks for this test. So I'm showing this video, just watch carefully, PGs.
Okay. So I hope that is very clear and it explains everything. Right. Next is the costocrustal distance. What is that implication? Costocrustal distance is nothing but the distance between the iliac crest, top of the iliac crest, and the bottom of the the costal margin. So normally they say it is 4 finger breadths on both sides. That is a crude measure. We don't have an exact measure. And normally it is same on both sides and it is about 4 finger breadths. Next, in a case of scoliosis, you can see that there is an asymmetrical decrease on one side and an increase on the other side. Whereas in a high-grade spondylolisthesis, what happens is the costocrustal distance decreases symmetrically on both the sides. This is because the L5 vertebra has slipped forward and the trunk has shortened. So the costal margin comes below to rest on the iliac crest. Sometimes in severe cases of spinal deformities, it can rest on the iliac crest and cause costocrustal impingement and pain. So this is the importance of costocrustal distance. Next, limb length discrepancy. It is very important. So limb length discrepancy is important because compensation for the hip occurs at the spine. Okay. And fixed flexion deformity of the hip is compensated by an exaggerated lumbar lordosis. Abduction or adduction deformity of the hip is compensated by a scoliosis. Here you can see that in a fixed adduction deformity, it is compensated by a scoliosis with convexity towards the affected side. And there is also a downward pelvic tilt causing apparent limb lengthening. Whereas in a fixed adduction deformity, it is compensated by a scoliosis with convexity towards the normal side. There is an upward pelvic tilt causing apparent limb shortening. See, for those who don't understand, this is not complicated. Just go and read, you'll understand. The important thing is that don't forget to measure limb length in a case of spine disease, because if there is limb length discrepancy and there is an associated hip arthritis, then the problem will be in the hip and you will be missing that, and it is not a spine case. So be very careful about that. You have to diagnose the case completely. They won't say that this is a spine case and examine, or this is a hip case and examine. So you have to find out whether the scoliosis is due to a hip problem or it is due to a spine problem. So that is the importance of limb length discrepancy. One second. Yeah, next. These are the ways of measuring limb length discrepancy. Either you can do it in supine position after squaring the pelvis, or with standing with block beneath the shorter limb. You can have standard measured blocks. Okay, what is arm chest distance? In scoliosis, if you are writing D and B, then you can have a scoliosis case. There is unequal gap between the arm and the trunk in scoliosis. So this is called arm chest or arm trunk distance. Okay. Anthropometric measurements are very important. You have to measure the upper segment, lower segment ratio and compare the arm span with the standing height. This is especially important in Marfan syndrome and in achondroplasia. The lower segment is measured from the pubic symphysis to the floor. Then you measure the total height. Then you subtract the lower segment length from the upper segment length. In adults, it is 0.9. The ratio is 0.9. Okay. The ratio in Marfan and achondroplasia is different. Next, coming to the nerve root tension signs. So the best way to learn is from your mistakes. So I'll tell you, here is one of my PGs. I should thank him for doing this during the COVID time. He is doing the straight leg raising test in a patient with a right L5 radiculopathy. So I want you to know the mistakes what he is doing, right? Is a patient with a right L5 radiculopathy and he is doing the test, okay? Okay. One second. I'm stopping here. Can I have one of the postgraduates to tell me what the mistake is?
Any of the volunteers can answer.
Yeah. Gunashekar or Mahesh, anyone, or Bonesh. You want me to play the video again? See, he's doing a straight leg rising test. Okay, this is very, very basic, very important. This is not complicated stuff, but PGs get caught easily during these things. Without doing this, you are not going to examine a case of a radiculopathy.
Somebody tell.
Be bold, Pa. No, it's not an exam. Okay, basically you learn. That's it.
You think this is correct or you find some mistake? Somebody answer.
Correcta, tappa? Tappuna enna tappu?
Magesh,
What is wrong?
Guna.
Feel free, feel free, feel free.
Magesh, you can answer. If you say it's correct, say it's correct. Or tappuna enna tappunu solunga.
Whatever you feel, just tell. Okay.
One fellow said knee should not be flexed.
Knee in flexion, sir.
Okay. Knee should not be flexed. அடுத்தது, the patient with a right L5 radiculopathy. So what do you think was wrong? What is the basis of any test? See, first you do on the normal limb. Straight away he has done on the right side. So that itself is wrong. So for any test, see, you have to explain the patient, take time to explain the patient what you are doing. The second is, the patient should know that you are going to do this, because for the patient it is new. You would have read 100 books and come for exam. Suddenly if you catch hold of the leg of the painful leg of the patient and lift it up, he is going to wince in pain. So that is not polite. So first and foremost, you should tell the patient, I'm going to lift your leg, and this is how I'm going to lift your leg. I'm going to lift your leg to this much height. All this can be done on the normal limb. And next, you will have a clue as to whether he is having a hamstring tightness or not. Also, that can be assessed. So see here, the first thing is, he is doing it on the right leg. Right leg is the affected leg. That's the first mistake. If you see below, I marked the angle as 90 degree. What is the mistake here? I'll come to that later. We'll go to the next slide. This is myself doing the test. Now watch. First, you have to talk to the patient, ask him which leg is painful, and he points it to the right leg. And I'm telling that I'm going to do the maneuver on your normal leg. I'm reassuring him. And I'm feeling for the hamstring, whether it is tight or not. Then I am placing one hand on just above the knee to make sure that the knee is not flexed and it is kept fully extended during raising. I raise only up to 70 degree. All the time I look at the face of the patient. Okay. And next I will be doing on the other leg. I think one second. Yeah, so this is the affected leg. So I'm doing on the affected leg. Now watch the face of the patient always. Don't ask him, is it painful? Don't ask. Once it is painful, the patient will automatically lift his hand and say that it is painful. Okay, see, he's saying that it is painful. That's all. After that, you lower down. So this is the way you do a straight leg raising test. So why you should not lift it to 90 degrees? See, a straight leg raising test is positive only up to 70 degree, and the first 0 to 35 degree, the sciatic nerve is slack. The nerve, the dura is slack. Basically, straight leg raising test is a nerve root tension sign. You tense the dura, you tighten the dura, you give tension on the dura, so which irritates the nerve root and reproduces the pain. So the first 35 degree, the sciatic nerve is lax and there is no dural movement at all. In 35 to 70 degree, the sciatic nerve gets tensed and it gets rubs over the intervertebral disc, and during this range, you get pain. So straight leg raising test is significant only between 35 to 70 degree. Above 70 degree, whatever may be the amount of exertion, most patients will have pain, and this can be due to pain from the joint, hip joint. So after 70, no further tension of the sciatic nerve occurs. So always when you say straight leg raise, the straight leg raising test is positive at what level? It should be below 70. Don't say the SLR is 90 degree on the right side and 80 degree on the left side. Then you are already gone out of the exam. So it should be only less than 70 degree. You should say SLR, straight leg raising, on the right side is 60 degree, and on the left side it is normal 70 degree. So at 60 degree, which means on the right side it's 60 degree and it's painful. I hope I'm clear. So this is very, very important. Next, what is cross straight leg raising test, or it is called the well leg raising test, because you do it on the normal leg. A straight leg raising maneuver done on the normal leg will produce pain on the affected leg. On the affected leg, whenever you're lifting the unaffected leg, it can produce pain on the affected leg. This is called a well leg raising test, you raise the normal leg, the pain is on the affected leg. This is because in case of a sequestrated or an inferiorly migrated disc, it can it can irritate the nerve root in the axilla and produce pain on the affected leg. Whenever you are doing a SLR on the normal leg, the tug on the nerve will pull the contralateral nerve root against the disc, the affected nerve root, and cause pain. Okay. So this is the Bragard test. So Bragard is the next most important test. This is one of the postgraduates performing a Bragard test. You kindly note and let me know what is wrong. So he is a patient with a right L5 radiculopathy. See, I have taken all these videos last week. Okay, so basically because to teach you from your mistakes. Okay, this is not easy during COVID time. So you can interact. Don't feel bad.
Yeah.
Yeah, tell me what is wrong in this Bragard test. So this is the right leg. The first thing that is wrong is he is doing on the affected leg. Always do on the normal leg. Don't do on the affected leg. That is very important. Okay. Now the patient is saying that he's having pain. Then he's lowering down the leg and dorsiflexing the ankle. Okay. Right. So this is the correct way of doing it. First, explain to the patient what you are doing and ask him which leg is painful. So right leg is he indicates that the right leg is painful. Then you tell him that I'll do it first on that leg and then this leg. Okay. So I'm lifting the normal leg. You watch carefully. I will not lift the leg up to 90 degree. The leg should be lifted only up to 70 degree. After that, there is no role for a straight leg raising. After that, even you, me, or anyone will have pain. So that is not right. So this is the affected leg. So he's complaining of pain at that level. 1 second. Okay. So he's complaining of pain at around 50 degree. Then I am lowering the leg by 10 degrees. Okay. Now he says that he is not having pain. Then I dorsiflex the ankle, which again will stretch the sciatic nerve and it will reproduce the pain. It should reproduce the pain. Okay. See, he's complaining of pain. That's it. Okay. Now, next is the bowstring test. What are the common mistakes made in the bowstring test? 2 postgraduates are performing the bowstring test. Watch carefully. Next, I'll tell you how to do it correctly. These 3 tests, without doing these 3 tests, you are not going to clear the exam. So it's very, very important. Whenever you get a case of disc prolapse or a case of a spondylolisthesis with a radiculopathy, you are going to be asked to perform these tests. So he's lifting the leg. Watch him carefully. He's putting pressure on the popliteal fossa. At the same time, he's lifting the leg and the patient is complaining of pain. This is the second postgraduate. See what he's doing. Watch carefully. So he's explaining to the patient. He's lifting the leg. So already he has put pressure on the popliteal fossa and he's lifting the leg. Patient is complaining of pain. Okay. So this is not the right way of doing the bowstring test. Now watch carefully. You explain to the patient. Yeah, and he's saying he's having pain on the right leg. I'll directly do the test on the right leg now. For want of time. So you catch hold of the leg, place the other hand just above the knee to not to bend the knee. Then he complains of pain at 50 degree. Then I just flex at the knee. Okay, this is very important. I'm not lowering down the leg. I am flexing at the knee. After that, what I do, I put pressure on the posterior tibial nerve at the popliteal fossa and the patient is having pain. So this is called a bowstring test. Okay. Now, so mostly we talk about L4, L5 disc, L5, S1 disc, and patient is having L4, 5 or S1 radiculopathy. But very important thing is that if the patient is having an L2, L3 disc, he will have a femoral radiculopathy. In that case, you can't do a SLR, straight leg raising test, and say that the patient is not having any pain. You have to put the patient prone and do a femoral nerve stretch test. So you put the patient prone, you flex the knee, right? Then you stabilize the pelvis and you lift the thigh, you extend the thigh. The patient will have pain. So this is a femoral nerve stretch test. Okay. The patient is complaining of pain, then you lower it. So this is very important. It is indicative of a L3 radiculopathy. Next, very important thing. In a case of a lumbar spinal stenosis, I said that the patient will have paucity of signs. He will not have signs. And especially he will have signs only when the examiner is examining. And when you are examining, he will not have neurodeficit. When you are examining, he will not have weakness and he will not have any pain. When the examiner is examining, the examiner will sit and ask the patient to come and examine him. And he will have all the symptoms. You will say L4 is not weak. He will have weakness of L4 when the examiner is doing. The trick is that whenever you are doing, the patient is lying down and resting, he is not going to have symptoms of claudication. By definition, claudication is the presence of radicular symptoms or numbness or heaviness in the leg only after walking for a short distance or exerting. So normally you should say something called a claudication distance in history. So you should say that the patient is having symptoms of claudication at a distance after walking a distance of 200 meter or 100 meter or 500 meter. So what you do is you can't, sometimes you may not have the space to make the patient walk. So you ask the patient to sit and get up, let him do half squats. So once he is doing half squats, at a point he will get tired and he will have symptoms of pain, reproduce the symptoms of pain. He will have pain on the posterior thigh, the radicular pain will arise. Automatically he'll say that I can't do it anymore. When you at that point examine all the neurology, see he is slowing down. Just a second. He is slowing down and when he is having pain, he'll automatically go drag his feet and sit down, right? This is the point where you perform a neurological examination and you have all the symptoms and signs, right? That is very, very important. Re-stressing the patient of a lumbar spinal stenosis to produce claudicatory symptoms. Common, next I'm going to the jerks, knee jerk. I'm not going to say which are the tests and which are the muscles to be tested for L4 radiculopathy, L5 radiculopathy, all that Professor Nalliuraj sir has taken. And I am just hinting you at what mistakes you commonly make and you rectify it. That is going to be the way forward. And that is the best lesson you can take home. See, this is, one second. This is one of my postgraduates. Okay, he's performing a knee jerk. Just watch, just observe. And for this, I need an answer as to what mistake he's making. One second. Okay. Okay. Just watch carefully. He has done it now. This is the second postgraduate doing the knee jerk. Okay. Right. Okay. Now tell me the mistakes they made. Mahesh, Bonesh is there? Gunashekar? என்னப்பா தப்பு பண்ணாரு அவரு?
Mahesh, Shenthil, please come forward.
Mahesh, hey, this is knee jerk. You have been doing it all around the year. I'm just asking what is the mistake with the knee jerk. See, don't feel shy. Come forward and answer.
The contraction, contraction of the quadriceps should be felt, sir. So the hand should be placed over the quadriceps and the contraction should be felt, sir.
Okay. This is Mahesh. Okay. Where? What mistake the first PG made? See, there are two mistakes. The first PG, what mistake he made was he Both of them, they have to take time to expose the quadriceps first as much as possible. Second, you feel the patellar tendon. Third, the first PG didn't swing the hammer. You can't strike the hammer. You have to give a swing. Then only the knee jerk will be elicited. And you should not keep your hand on the quadriceps. You have to observe the contraction of the quadriceps. You cannot keep your hand and feel the contraction of quadriceps. Okay? You should observe the contraction of the quadriceps. Now watch this. First, expose the muscle which you want to visualize, and you have to see for the contraction. Next, this is the patellar tendon. Feel the patellar tendon. Explain the patient that I'm going to strike the tendon with a hammer. Okay. Now, you have to swing the hammer. Don't tap hard. You have to swing the hammer. You see the contraction on the next beat. Wait. You have to look for the contraction of the quadriceps. Okay, can you see the quadriceps contracting? You have to look for the contraction of the quadriceps. That is very, very important. Okay, right. So swing the hammer. Don't tap and don't do without exposing the quadriceps. So this is eliciting ankle jerk the correct way. Okay. There are many ways of doing, but this is one good way of doing. You can also place the patient supine and do it by, you first observe this and I'll let you know. So always feel whether the foot is relaxed and then take the knee hammer and swing it. Don't tap. Yes, you have to swing. It should come like a pendulum, right? So you can see that and you watch the contraction of the tendoachilles. That is the way of eliciting ankle jerk. The other way is you can make a figure of 4 and place this testing limb on the other limb and test the ankle jerk. Okay, this is one common mistake which postgraduates make. Testing the power of extensor hallucis longus. So extensor hallucis longus originates from the anterior surface of the fibula and adjacent interosseous membrane, and it goes all the way down and it inserts into the base and dorsal center of the distal phalanx of great toe. It extends the great toe and dorsiflexes the ankle. Okay, so this is one of my postgraduates doing a EHL testing. Okay, the problem here is he is placing his thumb on the interphalangeal joint, and that is not the way to do it. You have to place the thumb on the distal interphalangeal joint, and you can see the prominence of the extensor hallucis longus tendon. So that you have to observe, right? And you can tell the patient to do it before giving for any muscle testing. You ask him to do it and make sure that he has grade 3+ power. Then you test it. But many textbooks, they say you can place your finger on the interphalangeal joint, but you should watch that the EHL goes all the way down and attaches to the base of the terminal phalanx. So the pressure should be on the terminal phalanx. Okay. And this is a very important thing. You made all the diagnosis and you're going to localize the level of the lesion. So you should know which root is involved. Suppose you have findings in the L5 dermatome as well as in the S1 dermatome. So can you say that the patient is having L5 and S1 radiculopathy? Is it right? Postgraduate. Can you say that the patient is having L5 and S1 radiculopathy if he has weakness of L5, weakness of S1, as well as he's having pain along L5 and S1, and he has sensory loss in the L5 and S1? Can you say yes or no? I think Sivakumar sir will be taking it from here, sir.
Both, yes. Are you able to hear me?
Yes, sir. Yes, sir.
Yes.
So actually, the thing is, before it was considered okay, but now see, the logic is, if you are saying that you are having a L5 and S1 radiculopathy, then I think you have got a clue that there is an involvement of the L4, L5 and L5 S1 disc. See, in exam, most examiners, some prefer you can say both, but most examiners, they prefer you have to say one root. And how will you arrive at that root? See, this is the anatomy of the disc, right? So you always have, you see the picture on the far right, you always have there are 3 levels: L4, L5, and S1. This is the L4 pedicle, L5 pedicle, and S1 pedicle. So the L4 nerve root exits below the L4 pedicle. This is the L4, L5 disc. The L4 nerve root, even before coming to the L4, L5 disc, it exits beneath the L4 pedicle. Whereas the L5 nerve root travels over the L4, L5 disc. It is called the traversing route and exits beneath the pedicle of L5. Whereas the S1 nerve root travels through the L5 S1 disc. It is the traversing route and exits beneath the pedicle of S1. So an easy rule to remember is that if it is L1 pedicle, the L1 nerve root exits beneath the L1 pedicle. The L3 nerve root exits beneath the L3 pedicle. L4 below L4, L5 below L5 pedicle, and S1 below S1 pedicle. So these pedicles, these nerve roots exit. So even before coming to the L4, L5 disc, the nerve root has exited. So the only nerve root which is traversing through the L4, L5 disc is the L5 root. So suppose we'll take the scenario of L4, L5 disc. The most common situation of a lumbar disc prolapse is paracentral, this region. So this disc will affect the L5 root, which is the traversing route, and the L4 root will escape from the disc. So a L4, L5 disc most commonly will present with the L5 radiculopathy. And the next disc is a superiorly migrated disc. That disc can involve the exiting route. And the third scenario is a far lateral disc. This disc is the one which can involve the exiting route at L4, L5. But the most common presentation of a paracentral disc will affect only the traversing route. So for a L4, L5 disc, it will affect the L4, L5 disc extrusion or protrusion will affect the L5 root commonly. So whenever there is an L4, L5 disc prolapse, whenever the patient is having an L5 radiculopathy, then the diagnosis should be, it is most probably due to a L4, L5 disc. Suppose the patient is having L4, L5 and S1 radiculopathy, then what will you say? Is the patient having an L4, L5 disc and a L5, S1 disc, which is a uncommon possibility, or the patient is having a huge L4, L5 disc which can compress both the L5 root and S1 root. So that is the more common possibility. A multi-level disc is not so common, but a single level large disc can compress multiple roots. The same holds good in a cauda equina, where a huge central disc can produce bilateral symptoms because it compresses multiple roots at a single level. So this disc will compress L5 and S1 root, but the L4 root will escape. I hope I am clear. Okay, the most common question asked. I am given only 15 minutes for a short case. Should I examine the CNS? There is no spine without the brain. Please be clear. Examination of the spine is never complete without examination of the central nervous system. You should be shrewd enough to examine higher mental functions. After all, what are you going to examine in higher mental function? If the patient has been talking to you all the time for 10 minutes, when he's giving sane answers, sensible answers to your question, then automatically higher mental function will be normal. So you are not going to say speech is normal, the memory is normal. So you are going to test remote memory, you are going to test recent memory, everything. So you are not going to do a specific set of examination for that. Cranial nerves. See DOS. And DOS has one good test for each cranial nerve. And you can ask the history for most of the cranial nerves, have your examination kit, and the examiner is rarely going to ask, but in case the patient is having an obvious facial nerve palsy, you should be able to pick it up. Okay, so that is very important. Next, key examinations not to be missed. The dorsal pedis pulse and posterior tibial artery pulse should be palpated always, and that should be reported, because whenever you are talking about lumbar canal stenosis, lumbar spinal stenosis, you can't say it is neurogenic claudication when the pulses are feeble or absent, or when there are ischemic ulcers. So always feel the pulse. Then the million-dollar question is always, where will you feel the dorsalis pedis pulse? Okay, so I'll go to the answer for want of time. This picture has been taken from one book which all the doctors have seen. This is Cunningham. Okay, this is the extensor oralis longus tendon. This extensor oralis longus tendon, we have seen it attaches to the base of the terminal phalanx. And here you can see that I marked in red. The dorsalis pedis pulse is felt in the first intermetatarsal space and between the base of the first two metatarsals, lateral to the tendon of extensor hallucis longus. This is very important. Okay. Next, the posterior tibial pulse. This you know very easily. I marked. It is just behind the medial malleolus. I've just put the anatomy here as well. And one more thing is, never fail to examine the sacroiliac joints, hip joints. That is also very, very important. Okay. Right. That's it. Thank you.
Kumar sir, your expert opinion or expert any added points you want to add?
He has very nicely described all the signs and symptoms of back examination. Is nicely described. And the one thing I would like to add is the chest expansion. I think he has forgotten. Chest expansion is very, very important, and it is because the ankylosing spondylitis is very common in our area. The chest expansion will, and SI joint, hip examination, and the chest expansion is a must. When you use the tape, you must do the first chest expansion. Then the chest expansion is very important. Then the Schober's test. And another thing is very good. And another thing that regarding the SLR, when you say, most of the people think that back pain is positive for SLR. It's not the back pain, it's the radiating leg pain. It's a positive for SLR. It's not the back pain. That you have to keep it in mind. And the patient says pain in the back, lower back, it's not a positive SLR. It's a nerve tension sign test. And another thing, what you said, SI joint examination is very important. And the difference between the neurogenic and vascular claudication, it is very given in all the textbooks. And that one has to be there. And sometimes you mind that a patient will have both neurogenic and claudication, vascular claudication together in some patients. Because nowadays diabetes is very common, and the patients will have both claudication at all. It's very, very difficult. And you should see that the neurogenic and vascular claudication differences. Everyone, they will, the theory and the practicals also they ask, and the clinical examination is very, very important that you should read it in the textbooks. Or you can tell what the difference between the neurogenic and vascular claudication.
You sir.
Hello.
Okay.
You sir, you can.
Sir.
That's all.
Thank you, sir.
Anything else you can? Yes.
Sir, Thanapan, sir.
Yes, sir wants to go for some poll, and he has listed one question in poll.
No, I think it's we have already time, sir.
So actually, it was very extensive coverage, sir, from both of them. One, Dr. Vishnu had given a very clear case scenario, and from there he built it up very slowly from history, clinical examination, and then radiology, and from there he went on how to treat. I think that is a sequence that every postgraduate has to learn, and he has given us a very clear way of how to approach a clinical case, not only spine. In fact, any case should be approached in that manner. I think it was really well taken by Dr. Vishnu. I think big kudos for him. And of course, Dr. Aju Bosco was very methodical in clinical examination, because he was very particular that everybody has been taking the correct way. So he wanted to show them how the mistakes is being done, and from there how to correct it. I think that was a very different approach today. I think so far we have not had such kind of approach. So how mistakes are commonly made and how to correct it. I think normally we do a lot of mistakes. And Aju, one thing that I want to tell you is, it is always better to learn from our mistakes. It is always better to learn from others' mistakes. And
Yes,
especially as a surgeon, I think if you learn from others' mistakes, it will not be very costly. I think postgraduates and everybody should take that point that it's better to learn from others' mistakes. And even in exam, if somebody does the mistake, you should know first that he is doing a mistake. I think that is also important. So we had a two great, wonderful sessions. Of course, it was a little prolonged, but definitely it's very worthy for postgraduates to, and the experience of Sivakumar sir is always there for us. For today, he was behind, a few points that you missed. Even the chest expansion, sir, immediately he picked it up. I think that is the seniority, I think, and experience that sir has. So thank you, Sivakumar sir, first for giving us your time. 10:30 வரைக்கும் உங்களை வந்து உட்கார வச்சிட்டோம் சார்.
It's a great opportunity to listen to those excellent lectures.
And a
excellent.
great opportunity for us to interact with you,
Yes,
sir.
yes, yes.
And and also Dr. Aju and Vishnu. And Vishnu and Aju are two young, very enthusiastic spine surgeons.
Yes,
We
yes.
understand from today's thing, and definitely we'll make use of them in our future,
Yes,
teaching
definitely.
programs. And definitely, yes, sir. I think both
Thank
of
you,
them
sir.
done a wonderful job, and thanks for taking so much pains and doing it. I think that
Thank you,
is
sir.
more important, and so thank you once again. I thank our TNOA team, also Dr. Thanapan, Dr. Suresh, and our advisors, Professor Singadil sir and Professor Vettivel Chedian sir, our president and secretary. And also thank Alambek for for rushing through from he rushed from Pondicherry to start the session, and he's still awake to for our sake. So thank you once again. I also thank the postgraduates. Hope there's a lot of points to be taken today. They better go back and read the textbooks. And so Aju, நீங்க உங்க textbook ஒரே ஒன்னு from Dr. Vishnu and Dr. Aju, from
Yes, sir.
what textbook to learn, அது வந்து நீங்க you can put it in the TNOA teaching program,
Yes,
those
sir.
WhatsApp groups. I think it will be very useful for them.
Sure,
So
sir.
I think that one point alone, they'll go and read what are the books supposed to read. I think from here we'll I think thank you once again, and I know
Thank
it's
you,
getting very late, so I think we'll close off for
Thank you, sir.
Thank you, sir. Thank you, sir.
lot of
Professor. Thank you,
yellows
sir.
பாக்குறேன் சார்.
Thank you, thank you, thank you
supporters
all.
என்னன்னு தெரியல, lot of yellows are there. சிவகுமார் சார் yellow தான் போட்டிருக்காரு. Thank you, sir. Thank you so much.
Thank you, sir. Thank you.
Sir,
Right.
Thanapan sir, thank you, sir. Thank
Thank you
you.
all.
Thank you.
Good night.
Thank you, sir.
Thanapan.